you, Atul.
Thank you, everybody, and thank you, VRSI, for including me in your very prestigious this VRSI uh, me, discussion webinar, because we're going to lay down actually some very major guidelines which will add on as an extra or probably to the already existing AS guidelines. So it would be good from various subspecialties we have thrown, because we know exactly what is required and what is maybe superfluous in the case of retina case. So I'm going to tell you about the elective and emergency surgeries, and what are the ones which elect an emergency, and what kind of tests should be important, and what else is important in such cases when they come to us for presumably for surgery. Somebody mentioned there's a new normal. So yes, there is a new normal, and have to adapt to it, and with hope, with time, that things will settle down. But the second wave could not be a pandemic wave. That's what one people say, because there will be a certain amount of immunity. So it'll be more of a asymptomatic wave with very few cases who have not been infected before and who have poor immunity to be affected. So the second wave is not going to be as drastic. It will be very less. So don't be so pessimistic about it. It's going to be a very mild, if at all. In fact, many persons will go asymptomatic. And soon as herd immunity comes in, we will find that many of us are just like BCG positive. We'll also be probably after the flu injection shots, we'll also be COVID positive. So that's what we are waiting for. And let's be a little optimistic about this disease. It's just a flu virus. The only thing is new virus, and just introducing to all of us and mainly the audience. We all know about it. So it's the natural reservoirs of bats. Bats are very high immune system, and unfortunately, they carry thousands and thousands of millions of very virulent viruses. But because of the extreme high degree of immunity, they never get infected themselves. They don't develop fever, they don't develop any respiratory problems, nothing. Live happily. But the thing is, if you trouble them, you eat them up, then it's going to be a major problem. And that's when you have zoonotic diseases like one we are facing now, the Wuhan coronavirus disease, which started by consumption of wild animals, including bats, civet cats, and pangolins. This happened in 2012, which caused SARS. SARS, fortunately, died down, and the genetic structure of SARS is, as well as this coronavirus, new coronavirus now, the new novel virus is about the same. So based on that, the genetic linkage, they're calling it SARS-CoV-2. So they're going to come out with a vaccine which is going to be faster, because the genetic makeup is the same as the SARS 2012. And companies are rushing to make the vaccine. So we should be hopeful from that front also, besides the second wave, as people are calling it. So India has responded quite dramatically and quite efficiently. There can always be objections to this, that we could have done it earlier. Everything could have been done earlier, but we at least went with a travel ban and lockdown. And I was seeing figures today. We've restored 31,000 in India cases, in which 20, nearly 8, 9,000 have recovered completely with two negative RT-PCRs. So we've actually got only about 21, 22 cases, 1,000 cases left in the country, and there's a dipping of the flattening of the curve, as you call it. There's a dipping of the curve in the last 5 days. They check the number of cases every 5 days. So the 5-day period shows the last 10 days there's been a dipping of cases. Now the government has also set in a Progress Setu app, the Bluetooth app, which is useful for us of retina specialists also, because it's a tracker which you can just download from the government MyGov site, the Ministry of Health and Family Welfare, and you can actually fill in all your data about your health and everything. Other person, who everybody needs to do it, because you will actually know whether there is a patient who's COVID positive and is in your area. So you know exactly where you are, what kind of people are around you, if you're sitting in an aircraft or wherever. It may also act as uh, if you're to the phone at the airport, if you see the green, then they'll know that you're absolutely away from the infection. So that may help you to get through the initial, which is because they say if you have a respiratory infection, you're not carrying a mask, won't be allowed to enter the airport. So all this would be important to have this happen. Now, coming to retinal surgery, this is going to be evolving. What is emergency and elective or non-elective today is probably going to change in 3 months. So we've now entered probably the COVID at the junction of the COVID non-COVID era. We're still getting out of the COVID era. So we're not saying that we have come out of it. We're just saying we're reaching towards the end the way it looks like. The government and most states have also have said that they continue for 2 weeks, but many have said that it should be a partial lock lift lift of the lift of the lockout. So emergency urgent and non-urgent is elective. So that's what the IGO says elective. So it's non-urgent by the ASCRS. So why should we differentiate cases? It's important because we are going to be getting very close in seeing these cases in the outpatient. Some of them may present only 1% reports are there from the published articles that conjunctiva infection is with follicular conjunctivitis only seen in 1% cases of COVID positive patients. They may develop during the course of COVID disease when they are admitted in the ICU or they're in the isolation ward. They may develop in the midway some conjunctival congestion. But it's not that you got to treat them with chloroquine drops or anything. It's just an ordinary symptomatic treatment for any viral conjunctivitis. The SARS and the tears, so there were a lot of controversies whether it was there or not. But recently, a very nice article has come out. It's actually in PLOS in Ophthalmology 2020. This long-term study shows that the risk of SARS to transmission through tears is extremely low, which is a good sign. So the tears you would be less worried about, and but there's another thing that in China, Italy, who faced the brunt initially, they found a lot of ophthalmologists, ENT specialists. For that matter, even the surgeons and the anesthetists would be affected, and also the intensive care unit doctors because they are they are the ones who are directly exposed to these patients. So what are the emergency cases? Acute retinal detachments where the macula is still attached. Now here I'm adding due to lack of space ROP procedures like lasers, anti-VEGFs and surgery because they cannot wait stage 4, stage 5 or stage 3 for that matter. So acute retinal detachment where the macula is attached. But also if you've got a quadratic detachment, the macula is still on, the detachment is far away, it's an emergency. You also have a case where the acute detachment, the macula is threatened, or a case of a GRT. GRT I added myself, it's not there in the IGO list, and I just added it. And so these cases also come under the emergency category. Pediatric EUA, this has again not been added, and I feel retinal detachments which are picked up and then operated, blastoma diagnosis, trauma, you can get identify what all is there. You could see a foreign body. There's endophthalmitis or there, even Coats disease and all. Those patients do require certain laser treatment. Coats would require a laser treatment. The RB would require a brachytherapy, or would need to be treated as an emergency. I feel. Of course, trauma with the foreign body would need to get the foreign body localized and operated. Another important indication, which is there's acute endophthalmitis, severe visual loss. So we have to do a vitrectomy for this, but they also mentioned evisceration as an option, which should be an emergency procedure. The patient is painful, he's having exuding pus, a corneal abscess, he should get eviscerated. So they have included it in the American Academy of Ophthalmology recent update, which is bringing out every week, and but it's not there in our AIOS. The fresh submacular hemorrhage under the fovea, whether it's PCV induced or it's a aneurysm induced, but for a fresh submacular hemorrhage in the below the neurosensory retina, you must operate because it shears out the photoreceptor, very severe damage. Earlier we take it out, the better it is. Now, PRD in the macula again is in the, especially in the monocular patient, but I think even in bimonocular patients, this can be discussed. But I think these should be operated, and right now in emergency we are operating at our center. Patient fovea PRDs, patients are going down vision. Often their fellow eye is also having poor vision. It's because they are symmetrically. Open group injuries with or without foreign body is no question. This is operated as an emergency at RP center. We do it day in, day out. Even the night, because of 24/7 casualty running, we do it. Exposed buckles or anything, it's a rare thing nowadays, but if they are, we have to put them up. And then retained lens fragments, the elevated IOP, you have to take them up. Sorry. Elevated IOP, you got to take them out, elevated lens fragments. Or if you got malignant glaucoma, you need to take it out. If you've got malignant glaucoma, it's usually because aqueous miscorrection, you got to do anterior vitrectomy. So diagnostic with due to infectious causes and other causes. Yeah. Dense hemorrhage in the monocular bed. This is also mentioned. SCR is mentioned. The AI also mentioned the dense vitreous hemorrhage, whether DRVO induced, a vein block induced, whether it's a tear induced, or the PVD induced, or dense vitreous hemorrhage is coming under emergency procedures. I think the ASRS guidelines is given. So, enucleation due to any cause, whether it's a tumor, ocular brachytherapy, as I just mentioned, if there's a patient having a retinoblastoma or a melanoma, diagnostic vitrectomy for infectious and oncological etiologies. All this comes under emergency procedures. Now, this is a little macula on threatened detachment, which you need to take up immediately as an emergency. Giant tears, again, you have to take it as an emergency. And from emergency cases, we come to urgent cases. Here, the risk of permanent severe visual loss without immediate surgery is not as high, and treatment can be delayed for a little while, maybe a couple of weeks. It has not been specified how long, but it can be for a couple of weeks. And there you can see the detachment is already there. It could be a little older, but RD with PVR is also there. So they say membrane peeling is important. All procedures requiring membrane peeling, whether it's ERM or a PVR membrane, American Society of Retina Specialists says a membrane peeling conditions have to be taken as urgent, or even sometimes they say it could be an emergency procedure. So all these membrane, because if it is active PVR, then the patient's going to lose his eye by the time you wait, and his PVR will progress so much that you go into D3 or a D2. It's a narrow funnel RD, something which is not so appetizing for a surgeon, but rather if you've got a C1, C2, when you can actually operate and get away with very good results, something like we will consider as an urgent surgery, not waiting more than a week or so, 10 days. And in those period also give them topical anti-steroids, etc. That's what I do like to do. Retin fragment with medically controlled IOP, yes, as an urgent, can wait for a few days. If it's hemorrhage in which a tear or detachment is suspected, again, it's open to discussion, but I feel that if you got a tear or detachment suspected, it's better to operate as quickly as possible, because the detachment may spread. With a tear, it may spread to a detachment, and the detachment may involve the macula. And once the macula is off, the vision recovery is never the same. So, myopic traction maculopathy with foveal detachment, okay, it can wait for 2 weeks, maybe even 4 weeks. PFCL removal subfoveal is something which causes compression damage to the fovea and irreversible loss of vision. So, it should be taken within a week or two, not later than that. And severe VMT and acute FTMH is also being given by the American Society of Retina Specialists as you got acute VMT or acute hole formation should be taken as urgent because the visual recoveries are very good. That's what they say. Now, the elective surgery is the third part or the last part is elective surgery is non-urgent. They call it non-urgent. AIS calls it elective. So, surgery can be delayed without significant risk to further visual loss. So, chronic macular hole dislocated intraocular lens, if it's not causing any reaction and there's no lens matter, you can let it stay for some time. It's not causing any retinal break. Then it's also ERM, which is not acute in onset, or VMT not acute in onset. Vitreous hemorrhage, but no macular pattern PRD. Retained silicone oil, which can wait for some time. The pressures are under control. Now, this has also been given as this thing. Now, I'm not included anti-VEGFs because IAOS has totally excluded anti-VEGFs. And I think Raja or somebody is talking about anti-VEGF. So not included, but I can just tell you that AIOS has not put in. I went through the whole article. For practitioners, they have not put anything to do with anti-VEGFs. And we know that AMD patients require urgent injections. DME and vein occlusions can wait for some time, but neovascular AMD and PCVIs do require. So COVID testing prior to VR surgery and PPE for VR surgery, very important. Suspected cases, all pre-op cases. I feel we should get RT-PCR presently for 3 months with an X-ray test. I was reading on some WhatsApp group. They are also saying get the rapid antibody serum test. That is a very low sensitive, low specificity. It has errors. It may give you false positives and false negatives. So I don't know whether the House agrees to that, but I feel this is also a controversial thing that cases which you're going to do, because as you yourselves are saying, it's a longer duration surgery, so greater possibility of exposure. It's usually the respiratory exposure. No, If you get an ocular exposure, the surgeon gets to respiratory droplet, the patient sneezes or something, coughs violently, you have to irrigate your eyes with BSS and then wash eyes with covered in iodine. Or it's important to understand that this is a respiratory disease. It does not pass through blood. So that's very important. Even blood can be donated, and as long as the PCR is done, but usually they never find it. It's only the plasma. No, they're taking out plasma because of the antibodies, but there is no hematogenous spread. So a lot of things which we should be knowing that we have to. It's a respiratory basically disease, and we have to make sure we don't get the respiratory infection from the other patient, from a person. So every patient may be asymptomatic, can be a PCR, could be a COVID positive, could be a asymptomatic COVID positive. It's true. So we have to take our precautions all the same. So at RP Center, we are getting PCR tests right now for all our suspected cases, which generally suspected cases means if they have some fever, URT history, we send them to the infectious diseases SR, senior resident infectious diseases. But POP cases, we are all getting the RT-PCR as of now. X-ray chest also. And all of them till now, we've done about 15, 20 cases. All of them have been COVID negative. But if it's positive, then you probably send them for the initial checks and to the infectious diseases people and to the medicine department, and then wait for 2 weeks before they can give us clearance, 2 to 4 weeks, and then do the surgery. For PP, there's not much of change actually. We don't need to spend too much money on that. Splash-proof gowns are available by this many companies. They just gowns which have a non-woven gowns. So the front is non-woven, so the water doesn't kind of soak the gown in through and through. So that's okay, but I don't know how much is that fluid going to help you. Plus, because the fluid may not contain the virus. The virus is there in the eyes, but it will come out in the fluid. Yes. Face mask for self-infection. This is very important. So you got to wear. Ideally, you should wear a N95 or a three-ply, and the patient should wear a three-ply because see, N95 respirator basically prevents outside infection from coming in, and the three-ply prevents infected patient from transmitting his inside infection from out to out. So N95 is a great mask. Of course, we have short supply in the country, but it's a great mask for us doctors, for the medical care personnel, not only we are taking care in the COVID area, but non-COVID area also. You're the healthcare providers. We have to have the 95 on ourselves, whether in the OPD or whether in the theater, or you wear the reply with clipping all around. But of course, you've given the patient the mask, you'll say, why do we need N95? So probably it will go both ways. You've got a patient or a mask, you've got three-ply, you've got a patient or a three-ply, you've got enough gowns over the patient. Eye goggles, I feel, can be there because you have to basically protect your eyes, your nose. So your mouth, nose, and you been covered. The mouth and the nose has been covered. So the eye goggles, the transparent eye goggles would be better because the face shield actually fogs. We've had residents who worked in the NICU, in the COVID ICU and all. They said they were working at 3 by 60 vision because the shields notoriously fog up. So they say shields are absolutely useless, sir. They say we rather have eye goggles. So we can get these transparent goggles very reasonable. Probably this can be used, and an extra tip, I don't think so. This
Professor Atul, could you kindly conclude?
I'm just concluding. This is just showing you a 3D surgery here. We're sitting about 3 4 meter away. So the patient's face is here, and we're quite far away. So this really helps. You got protective glasses also. And this is the approach one, non-COVID patient. You can use a face shield in the OPD, but in the surgery, you can avoid the face shield and wear just N95 mask. This is only if you're doing a very heroic COVID positive patient surgery. And of course, my last slide is there's no end to putting on, various screens and, uh, you know, various buttons over your face, gloves, have gloves, but it's not going to make much of a difference that way. You should know what is essential and what is not essential. So we don't have to vie with each other that we have to really do something extraordinary. But I think if you take the necessary precautions, things should be fine. And I don't think the second wave is going to worry. We go to worry very